Wonderful that you can stay for sessions this long and you're right here to the very end. So we have one more presentation, and it's really important to us because many of us are confused with whether we should use SIRS therapy, or we should use chemoembolization, or we should use bland embolization in the cases of liver metastases. And we've got Brian Majoria here from New Orleans to come and talk to us about the choices and the conflict that we have at this time. Thank you very much.
Thank you. I appreciate the opportunity to come speak. I'm a tough crowd. But I gave a talk earlier this year over at Tulane down here in New Orleans, and I was the last speaker of the conference as well. I appreciate everybody sticking around. At that conference, my name tag was handwritten, so at least it's printed today, so I'm going to take any progress I can get. Well, what we'll talk about are the intra-arterial therapies. Okay. Okay. So I'll just kind of get this talk started. So what we'll be talking about are the intra-arterial therapies, and there's basically three different types of therapies that we'll be discussing: the bland embolization, the chemoembolization, and then the radioembolization. And what we're going to, what we exploit with this therapy is the dual blood supply to the liver, like was discussed earlier. The liver gets about 75% of its blood supply from the portal vein. Sure. The liver gets about 75% of its blood supply from the portal vein and about 25% from the hepatic artery, yet the tumors will get nearly all that blood supply from the artery. So by treating into the artery, we target the tumors and spare most of the normal liver. Well, the early experience with the intra-arterial therapies was back in 1974, where basically they ligated the hepatic artery in order to cut back the blood supply to the tumor. And this worked for just a short period of time, and quickly the tumors just reaccumulated or reorganized blood supply through the collaterals. So they had to look at doing further distal therapy, actually embolization therapy. So with the bland therapy, the bland embolizations, the particle therapy, there's many different types of agents that we use as far as gel foam, powder, particles, trisacryl particles, thiazole. And what we would see is a response. This therapy would have to be repeated every few months. And with the chemoembolization, we basically add chemotherapy to the mixture, and we can embolize. And again, that's also used with a wide variety of different agents, different type of chemotherapy agents, different type of embolic agents, from the thiazole, from gel foam to particles. And each has a different mechanism of action. With the bland embolization, what we're trying to exploit is the mechanism of action is the ischemia. Okay, with the chemoembolization, we're adding chemotoxicity in addition to the ischemia. Now with the, okay, all right, here we go. So I'll just jump through these slides. Okay. So our goal, again, with the bland embolization is just to block up the blood supply to the tumor. Ischemia is the only mechanism of action. It does require at least an overnight hospitalization, IV antibiotics. The post-embolization syndrome can be pretty significant: pain, nausea, fever, low-grade fever, and the risk of infection is also a possibility. It's just showing the arteriogram and then the tumors afterwards. With the chemoembolization, our goal is to deliver high doses of chemo agent and then to block off the blood supply. So the dual chemotoxicity versus the ischemia. And again, this causes a lot of difficulty in interpreting the results. It's just that there's a wide variety of agents that were used. There was no standard regimen, wide variety of chemo agents as well as the embolic agents. Lately, the DEB-TACE, which is the drug-eluting bead transarterial chemoembolization, has really sort of taken off. Again, these procedures are repeated every few months. They do require at least an overnight hospitalization, and oftentimes it's longer than that. Same with the IV antibiotics. Post-embolization syndrome can be pretty significant, and the risk of infection is also there. This is just an arteriogram on the left side, and then the image of the CAT scan shows the thiazole, the real bright spot, so just the thiazole taken up in the tumors. Now with the drug-eluting beads, so what we do in the top image on the left is the blue shaded beads, or just the bland beads by themselves. What we do is we mix that up with, usually a vial is mixed with 75 milligrams of doxorubicin, allowed to sit for anywhere from 1 to 4 hours. The beads will take up the chemo agent, then we draw off the free chemo agent, and then we infuse the beads. And the images just show the chemotherapy. You get basically a distribution throughout the liver and the body. Is very similar with the conventional taste with the thiazole. You get a higher dose within the liver, but you're still getting the distribution throughout the body. With the drug-eluting beads, it's a much, much lower dose that's going systemic for the chemotherapy. Most of it is just eluted over a period of a few weeks in the liver. Just some images showing the pre and post. We see a little bit on the left side images are before, and then the after images we see just the complete lack of enhancement, a little bit of gas as well from necrosis. It's just some PET imaging showing the tumor that decreases after the first and then the second chemoembolization. And with the yttrium-90, totally separate mechanism of action here. It's known by different things: radioembolization, selective internal radiation therapy, or Y90 microspheres. And our treatment goal here is to deliver very high doses of radiation selectively to the tumor, 100 gray or greater, while at the same time maintaining a very low dose to the remaining liver. And just the rationale, again, the liver is very radio sensitive, so about 30 gray, you end up with what's the veno-occlusive disease, or radiation-induced liver disease. And that's the reason why external beam radiation therapy is used very little within the liver, because you would kill the liver before you kill the normal liver, before you kill the tumors. The tumors may be radio-resistant. They can require up to 60 to 80 gray to be killed, although if you deliver enough radiation, you'll kill anything. And again, delivered in the artery, the beads preferentially lodged within the tumors. And this is a radiation effect. It's not ischemia. We actually want to maintain good blood flow to the tumors to maintain a higher oxygen tension where the radiation works better. We want these tumors to continue to divide while the radiation is working. This is just showing the tolerance. Again, the radiation-induced liver disease, you would hit at about 30 gray, but it may take much higher doses to kill the tumor. And was discussed earlier, it's a pure beta emitter. It only travels very short distances, about 2.5 to 11 millimeters in distance from the beads. Half-life is 64 hours. By about 2 weeks, it's fully decayed. This is just showing some images, some photomicrographs measuring the activity. And in the blue on the bottom left slide, the blue coloration is up to 100 gray of radiation. The green is up to 8,000 gray. It's anywhere from 1,000 to 8,000 gray. So that's a tremendous amount of radiation. You'd certainly kill anything if you can deliver that amount of radiation. There's two different Y90 microspheres, the Ceraspheres and the Theraspheres. The Theraspheres is glass. It has a higher dose per sphere. The Ceraspheres is a resin sphere. They both have yttrium-90. That's a lower dose per sphere, so you end up using more spheres. It's technically an off-label use whenever we treat. Actually, whatever we do now is technically off-label use. It's originally approved for treatment of colorectal cancer in conjunction with intraarterial chemotherapy, which is very, very rarely done now. So the patient selection, they should be in good functional status. The total bilirubin level is what we use to get an idea of the liver function. The liver should be functioning fairly well, otherwise you can tip patients over into liver failure with any of these therapies, particularly with the Y90. We certainly want the liver to the site of dominant disease. This is only going to be used in the liver. The arterial anatomy needs to be favorable. Portal vein thrombosis is not a contraindication. It's not as important with the carcinoid patients as it is with hepatomas. We look at the liver to lung shunt as part of our mapping procedure. That shunt ideally should be less than 20%, although ultimately we look at what the estimated lung dose will be for the treatment. And it can be higher than 20% shunt as long as that estimated lung dose is less than 30 gray for one treatment of 50 gray cumulative. We do a pre-treatment angiogram. So this therapy will require us generally to do 3 different procedures. One is the mapping, where we map out the blood supply, we block off the branches to the stomach or small intestine from the liver artery, and then we do the dry run with the particles, the technetium MAA that mimic the particles we use through the treatment. Will tell us how much radiation will go to the lungs. This is performed as a same-day procedure, so patients come in, get their procedure done, which is typically an hour, maybe an hour and a half, and then go home typically anywhere from 2 to 4 or 6 hours later. Very low incidence of side effects. Post-embolization syndrome is common, but it's much, much less severe than it is with chemoembolization or bland embolization. We usually will just do some pain medicine, antiemetics, and a steroid dose pack for patients to go home with. And so basically the radiation stays within the liver and then decays down from there. There's realistically no special radiation precautions that are needed afterwards. The amount of radiation next to the liver, if someone is for 11 hours straight against the liver, would be equivalent to 1 X-ray, so very, very minimal. Overall complication rate is quite low, about 5 to 10%. Ulcers are what we'll see more typically, even take very special care to block off all those branches. There may be some small branches that open up that we can't block off. Although they typically get better with just conservative therapy. Very rarely does that require any surgery, but those ulcers can be very resistant, last 6 to 9 months. This is a patient with islet cell tumor. So April 2005, he had that tumor in the right lobe of the liver. He was treated with the Y90, and 15 months later, the tumor's completely necrotic. This is another patient angiographically. We see the images on the top for his pre-treatment study. We see the tumors lighting up, and we see in the CAT scan, we see the bright areas of the active tumors. Back then, we were doing whole liver treatments twice. Now, what most people do is a lobar treatment. So we just treat one lobe at a time, get them back a month or so later, treat the other lobe. But back in these days, we were doing whole liver treatments. That's why I have the follow-up angiogram in between. But he had a complete response. It's another patient with carcinoid of the colon who we see the December 2005 images, the bright tumors in the right lobe, then the black spots, and then those fade out over the next 15 months. And this is a patient, there was the discussion about insulinoma, how bad of a disease this can be. This was a patient that Dr. Boudreau called me about. He had taken him to surgery, he had an insulinoma, he resected his pancreatic primary, had this huge liver mass in the right lobe, was almost completely replaced by tumor. Well, after surgery, for some reason his tumor got kicked into high gear. He was in the unit on a D50 drip. Couldn't get him out, otherwise his blood pressure was just total, his blood sugar was just totally dropping. So he called me to see what we could do, and not a good candidate for chemoembolization or bland embolization. With a tumor of this size, particularly with the carcinoid, you'd likely kill the patient trying to treat him. But we came in and did the yttrium 90, and basically what I did was a whole liver treatment to just his right lobe, because he had such extensive disease there. And within 2 days after the treatment, he was out of the unit, off of his D50 drip. He had really a remarkable clinical response. We had his symptoms controlled for about a year. Ultimately, he had some progression of his disease. He had some metastatic bone lesions as well, and he had to get hospitalized again, and at that point it was related to his extrahepatic disease. But you can see his right lobe of the liver is shrinking down. This is a radiation lobectomy. His left lobe has hypertrophy. He does have some smaller tumors in the left. This is another patient with carcinoma, and this is just showing on the right lobe versus the left lobe. We're seeing these fluid levels. That's from necrotic tumor versus the left lobe where the tumors are still enhancing. A very extensive disease. This is a patient that I saw who was basically told nothing could be done for her, go home and die. She had a bilirubin level of 15. She had extensive carcinoid in her liver. She had biliary obstruction. They could not get to her bile duct endoscopically because of the size of the tumors. So as a gastroenterologist from Tulane called me to see if I could do anything with her. So I saw her in clinic. We did her cholangiogram. We're seeing those images right here. And what we see is a severe stricture right at the island of the liver. Her right hepatic ducts were being compressed by the tumor. So first thing we had to do was to get her bilirubin down. So we put in an internal-external drain. We got her bilirubin down from 15 to 2 in a period of about 2 to 3 months. She had real extensive liver disease, treated her right lobe, treated her left lobe. Her bilirubin level was down to 0.8. We eventually put in metal stents, which we're seeing on the bottom image. Put in metal stents, got rid of her tube. She was tube-free for about a year. She had some progression of her disease. We put another tube in. She had tumor that was actually growing into her duct, and we re-stented her. And she survived for about 18 months with a bilirubin level of 15 after she was told to go home and die. And again, this is a patient with real extensive disease. Someone, if you were to do chemoembolization or bland embolization, you may do more harm than good. It's just showing a PEP response on patients treated. And just to discuss some of the results, and I'll apologize for this slide and a couple of the next slides, but I can't take credit for the confusion here. Big part of the reason this data is difficult to interpret is that there were so many different endpoints, so many different agents that were being used as far as chemoembolization or bland embolization, and we can see these are reported in anywhere from time to progression or 5-year survival or median overall survival, etc. We see effective treatment with each of these. This is comparing bland embolization to chemoembolization. Generally, we will see a higher response with the chemoembolization. It's just very difficult to compare the data directly. This is just comparing all three, the TACE, the bland embolization, as well as the yttrium. And we're seeing the top one, the TACE, is 25.7 months overall survival. We see the next is bland embolization, progression-free survival of 9 months. And then the DEB TACE, progression-free survival 15 months. The yttrium 90 originally with Kennedy was median survival of 26 months, ultimately a 70-month overall survival. So it's really a lot of different parameters that are being reported here. This is just showing the Y90, the SIR-spheres, and treatment of neuroendocrine tumor with liver metastases, and just showing the same information. Overall, we see a good objective response rate. Time to progression in these studies wasn't really reported, but the overall survival, median survival was for most of these. And I'm just going to go into detail for the Andrew Kennedy study, which was the largest. It was 148 patients. It was a retrospective review, 10 centers, all stage 4. And again, showing the response rate, we're seeing complete response 2.7%, partial response 60%, stable disease 22.7%, and progression in 5%. So overall, very, very good response. This is where they just break down different 82% were carcinoid tumors, small intestine was the primary site, most of them pancreas was next. Very low toxicity profile, a very well tolerated procedure. And again, just the response rate quite high. This does show we do see an elevation of the liver function test as well as the tumor markers about 2 to 5 weeks out, and then it decreases. So you can kind of see things look like they're getting worse, so we try not to check labs too soon after the treatment. And again, just showing some images pre and post treatment. This is just another paper by Robbie Murphy and MD Anderson. And these were patients treated with Y90 after they had been treated with hepatic artery chemoembolization. They had technically adequate, but they progressed. There was a small number of patients. There were 8 patients treated here, 1 partial response, 4 stable, 3 progression. Just 14-month survival, median survival, and 36-month from their diagnosis. Just showing that it is still an effective therapy after the chemoembolization as well. This was our information from here in New Orleans, hepatic artery radioembolization, the management of progressive metastatic neuroendocrine tumors, comparing the geriatric versus the young population. And since he's not here today, I'm going to blame that on Dr. Lowell Anthony for putting patients in the 60 age group and up as being geriatric. Not quite sure who's responsible, but he'll take the blame for it. And what we've seen is similar, somewhat similar to Andrew Kennedy's. We're seeing a 55-month overall survival for all comers, and progression-free survival of about 10.5 months. And just the conclusion here is that it is equally effective in all age groups and is independent of the primary site. Small bowel primary has a greater progression-free survival than pancreatic, although the overall survival is higher with pancreatic. The Chi-67 index is inversely proportional to overall survival and progression-free survival, and a higher KPS score correlates with better outcomes. The neurokinin A level is predictive of progressive disease at 6 months. Now I'm just going to go talk again, like Dr. Boudre talked about, the effect of the chemoembolization in particular on the vascular anatomy. Okay, this plays an important role in which therapy we decide to do first, and it certainly plays an important role in the way that I look at these therapies. Okay, this is a patient with hepatoma, but it was the same thing basically. We treated him with the yttrium 90 first. He did very well for quite a while. Then we did chemoembolization, and then then he progressed. And so what we're seeing is the anatomy is nice here, big hepatic artery. After we had done chemoembolization, we get him back in to do some additional therapy. His hepatic artery is just totally shot, and we just see multiple small vessels supplying the liver. And I'll get back to this patient in a second. And this is just comparing the size of the microparticles. So for the yttrium, these particles are very small, 25 to 40 or so microns in diameter. We get very distal penetration. Whereas with the beads for bland embolization, or now the dead TACE, we're using anywhere from 100 to 700 micron particles. And this is just showing the size difference. So it makes sense that we're going to cause some further damage to the blood vessels with those larger particles. This is that same patient. So what he did was he developed a very large phrenic artery supplying most of the liver here. He had supply from his kidney, from some omental branches, from all over. The tumors will get their blood supply from somewhere, but we can't really treat safely in those extrahepatic vessels. So what we'll try to do in this case is to block off all those branches we can and basically drive the blood supply from the more normal hepatic artery to try to get as effective of a treatment as we can. But there's no way we're going to get as effective a treatment in that patient afterwards as we will beforehand. When we do this is just, again, showing very similar things in a different patient. On this patient, I had blocked off, there's multiple coils, he had blocked off everything possible outside of the liver. And we see improved flow from into the liver from his hepatic artery, but it's still not nearly as good as if the anatomy were normal and we were doing the Y90 therapy first. Same thing, patient with normal anatomy treated, his right lobe was treated, completely shuts off his right hepatic artery with one treatment. His left lobe was treated, completely shut off his hepatic artery with the left lobe. And what he was left was basically his gastroduodenal artery, which is the one we block off primarily for the yttrium cases, was supplying his liver. So tried to block off all the other branches, and we treated from there. He actually got a decent response, but he did develop ulcers, which you would expect. It's been reported as very uncommon with the dead TACE, where you actually block off the blood vessels and damage those permanently. This is a case that I just received from Dr. Arpali in Atlanta, who had seen this patient treated with dead TACE. And here's the right hepatic artery completely shut down. And this is a case where, with the dead TACE, where it completely shut down the hepatic vasculature. So he ended up coiling and treated with yttrium approximately here, but we're just not going to get the effect that we like. So just in conclusion, which is best? Well, first of all, comparison literature is very difficult. For one, there's a very broad range of tumor types within the neuroendocrine tumor group, so it's hard to say, okay, neuroendocrine tumors are all going to act like this, because obviously they don't all act the same. Some of them are very sensitive to radiation therapy. Most of them are, but some of them aren't quite as sensitive, and you really don't know until you do the treatment how sensitive those tumors are going to be. No standardized TACE regimen, different end results like I talked about, with time to progression, median survival, 5-year survival. Overall strategy and consensus has not been reached as far as an optimal therapy goes. It is well accepted that the addition of either chemo or Y90 has improved survival and duration over bland embolization. Current research suggests that the survival is at least as good, if not better, with Y90, and patients definitely tolerate the Y90 better than they do the chemoembolization or bland embolization. Another important point, prior biliary interventions such as Whipple procedure, stents, or biliary bypass are not a contraindication with Y90. Very, very unlikely to get an infection with the Y90 because it's more of a gradual kill. You put the beads in, it radiates the tumors. It's more of a gradual kill. If you're doing the bland embolization or the chemoembolization, you're cutting the blood supply off quickly. They're going to get necrosis and they're more prone to develop infections at that time. In patients that have had a biliary bypass procedure, be it stent or Whipple or so, they have a colonized biliary tract, so there are bacteria in there. So they're much higher risk of developing an infection with chemoembolization or bland embolization. It's very unlikely with the yttrium 90. And again, the hepatic vasculature remains intact with the Y90, so it makes sense to consider doing Y90 first, and then we leave our bridges open to do any other therapy that we want after that. And that is it. I'd like to make that